So, thank you so much for having us. We'll do some introductions and then get on with it. Like I said, I'm Lori Cochran. I'm a speech pathologist. I work at Cook Children's Medical Center in Fort Worth, Texas. And I do see a lot of kids with apraxia. That's one of my loves and passions, one of my favorite things to work on. Okay, I'll turn it over to Teresa.
Hi, and my name is Teresa Jones. I also work at Cook Children's. Also, apraxia speech is one of my little specialties or interests within our field. I do enjoy also everything else that we're going to be talking about today, such as AAC. So we're excited to be presenting all this information to you tonight.
All right, so we'll go ahead and get started. So this talk, A plus B plus C, we're going to be covering a lot of material, and just kind of wanted to give you an idea of why we were interested in this information. So we do see a lot of kids with apraxia of speech at our facility, but because we are a medical center where Teresa and I both work on the outpatient side, we tend to get a lot of kids that are a little bit more complex. And yes, they may have apraxia, but they may have a whole host of other things going on. And so we just felt like we used a lot of different tools and thought that information would be helpful for sharing. So that's what we'll be going through today. Just some disclosures. We will be receiving an honorarium to conduct this presentation, but we don't have any other financial or non-financial disclosures. Okay, so just to review kind of what we'll be going through today, we'll be talking through some behavioral-based challenges that kids have a lot of times if they have CIS or if they don't. A lot of this information will be applicable to a lot of kids on your caseload. But we'll be talking through what an antecedent behavior and consequence sort of behavior analysis looks like. We'll be talking about how you can prioritize communication needs of those who do have CIS when you're thinking about your treatment plans. And then we'll be talking through lots of strategies to reduce communication-based behavior challenges and any other comorbidities that we'll be reviewing. So before we, let me pass it to Teresa.
So before we get started, we just always like to hear a little bit and learn about our audience. So Allison is going to pop up just a couple polls for us just to kind of get to know y'all. The first one of which is, what is your discipline? If you want to go ahead and vote on your screen.
All right, so we're seeing about 20% of our audience being speech pathology, 66% actually saying occupational therapy, 2% with physical therapy, and 12% saying other.
And then we've got one more question for y'all. Also a poll is, how familiar are you with childhood apraxia of speech?
All right, we have 8% saying new to me, 42% saying I've heard of it, 48% saying I know a good amount about it, about 2% saying I know a lot, and this is one of my specialty areas.
Great, thank you all for participating in those quick little polls. This is going to help us kind of gear this presentation more towards the crowd that is attending tonight. So it looks like we do have majority OT, but it's great to see that the majority also know a good amount of CIS going into this. So this will be great information and great for us to gear this towards you. We do have one more question for you. This one's going to go into our chat box or your question box of what exactly would you like to learn from this presentation today?
And all this. All right, so treatment ideas, current best practice, treatment strategies, anything to support a student on my caseload with speech apraxia and his AAC. Strategies to assist children dealing with frustration who do not wish to use alternative communication. A lot of treatment strategies, anything to support a student, my caseload, an AC, current best practice, bed teacher, practice 6 students, mama AAC user, I'd like to learn science and diagnosis seeking information on my 5-year-old daughter with suspected CAS, general strategies for apraxia, more on the AAC, practical strategies to use in the school setting, treatment plans, behavior management techniques and strategies, always open to new ideas to improve communication, more treatment strategies, simple suggestions to use when working with my grandson, OT for OT kids, Kaufman cards, do you use them? AAC, how to reduce behaviors due to difficulty communicating, visual schedules, use visual schedules, question mark, how do we give the child to help choose activities and follow a schedule, how to help direct behavior using communication strategies for students. It always confuses me when a student has CAS but doesn't have dyspraxia of hands or body. And how to best set up a session for a child with apraxia. Whew.
Thank you, Allison, for going through those.
Yeah.
I just jotted down just a couple notes, so then we'll be sure to kind of touch base on if we'll try to get to most of those topics that everyone mentioned.
All right.
Ready,
So oh, what's that, Teresa?
No, you go.
Okay. Yes, we're gonna jump right in and see if we can hit some of those. Sorry, I'm just rearranging my windows so I can see my notes. Okay. So one of the things that that we wanted to just do was really define this. A couple of you said you weren't as familiar with it, so we'll go through this information. And childhood apraxia of speech, the core issue is that it is motor planning deficits. So that means there's difficulty with planning and timing the precise movements for speech. And so what that can look like, it might be, you might hear vowel distortions, you might hear issues with prosody, so the intonation of speech. That could be word stress or syllable stress. They're not putting stress on the correct syllable of the word, or in more cases, they put excess and equal stress on both syllables of the word, or all syllables of the word. So if the word is bunny, typically I would need to say bunny and stress the first syllable. However, with a child with apraxia, you might hear bunny, so it's got equal stress, and they're just pushing a little too hard on both those syllables to try to get it out. Voicing errors is another big thing that you hear. So, some kids that have articulation and phonological disorders, you may hear a substitution like bat instead of pat, where the B is that voiced consonant. However, kids with apraxia don't usually quite make it that clear. Usually I hear a sound that's like kind of in between a B or a P, and it's hard to tell. And that is because they're having issue with the timing of that voice onset. So we're talking about milliseconds here, and all of these really precise movements that all of our articulators do, and timing them, the whole, all of it is just milliseconds. And so that timing can be really challenging for these kids. Also, a lot of inconsistency. So they may get a sound correct or in a word, and it may come out clear as day, and then 2 seconds later, they can't replicate it, or you might hear something wildly different. So those are just kind of a couple of the main things that we look out for. We will have a lot of resources for you on the last couple of slides in case you want to dive into more information that we can cover in just this hour and a half. So you can refer down there as we go. Another really big important thing to remember about apraxia is that you have to utilize dynamic assessment in order to diagnose it. This disorder is diagnosed by an SLP. A lot of times we have neurologists or pediatricians or random professionals coming in and saying, no, this child has apraxia, but the true diagnostic criteria need to be diagnosed by an SLP. And you have to utilize dynamic assessment to do that. So we know with standardized testing, and that is a good tool to use with these kids in addition to your dynamic assessment, but with standardized testing, you really can't give any cues to the child. You show them a picture, they say the word, you write down their errors. However, with dynamic assessment, we are utilizing a test, teach, test format. So you start off by having them say the word, noting their errors, but then we move into the teaching phase and you cue them with all the tricks you have in your bag, whether that's a visual cue, a verbal cue, telling them what to do, putting your hands on their face, you know, to kind of help them, give them tactile cues, any cue you have that can help them make the movements and the sequences of movements that are needed to to produce that word. And then you test them again and see if that cueing helped. So there is a really great assessment that we use a lot called the DEMS, Dynamic Evaluation of Motor Speech Skills, that is published by Edith Strand. That is in your resources, but many people do informal dynamic assessments as well. Also, another assessment tool that we included for you on the last slide is called the Mayo 10, and that goes into it's 10 characteristics of apraxia that you can use in your dynamic assessment to kind of check the boxes. And so that criteria is on that slide as well. The third really important concept is that treatment for apraxia must be based in the principles of motor learning. And that's just because this is a motor planning disorder, and without a strategy that's based in motor learning, you're just not going to see the progress, because a phonological approach or an articulation approach isn't getting at the core deficit. So there are a few great options out there for treatment techniques, theories, methodologies that do have some really solid evidence behind them. Again, this information is on your last slide. If you want to go through some additional training to get that information and be, you know, kind of brush up your skills on these, the first one is called DTTC. So this was developed by Edith Strand. It's dynamic, tactile, and temporal cueing. And all of the information is free to kind of be trained on it. It really is more geared toward kids that are younger and or more severe with CAS. So a lot of times this is a treatment methodology that I start with when they come to me as toddlers or preschoolers. We're not sure if they have CAS. Sometimes I just move right on in to this treatment methodology and treat it as if it is, just in case. And this is basically a hierarchy of the types of cueing and the timing of cues that you give, and kind of working your way from the most significant amount of cueing, which is simultaneous cueing. So we're saying the word at the same time at a really slow rate so that I can help you get through the word and all of the movements, and you're watching my mouth at the same time, versus kind of moving down the hierarchy, we're fading some cueing away. I'm cueing you less often, I'm not cueing you at the same time. We might go to more of a direct model. I say it, you say it later, that sort of thing. So that's kind of DTTC in a nutshell. Moving on to the second major treatment methodology that Teresa and I use, it's called REST, rapid onset syllable transmission. Mm-hmm. Yeah. And this one is out of Australia, the University of Australia. And if you go to the link on your page, that is the full, all of the videos that you would need to train, the manual and everything is all available for free as well. This is the other methodology that has a lot of good evidence behind it. It's a little different. It's really geared for kids who are who have progressed into kind of being more verbal. They're able to string together more syllables and words and phrases and sentences, and the treatment is based in non-words. So you would start with you know, 2-syllable or 3-syllable non-words, creating word combinations of vowels and consonants in the repertoire, and then kind of going from there. So great information. And so we'll move on and talk through next steps.
So one person did mention one of their questions they wanted to kind of learn was if we use Kaufman cards.
That's right.
So for me, I kind of gear all of my sessions based on the child, what words are powerful for them, or core words, or the nonsense words if we're doing rest. I more so use the Kaufman cards as like inspirations for what words to target, not necessarily as the Kaufman process that's listed out on the back of the cards. I would rather teach them the correct motor planning than an approximation and working into that. So the words of the Kaufman cards are great because a lot of them are core vocabulary words. So if I'm just having a day where I just need to think of what words I need to work on with this child, sometimes I'll reference those cards, but not necessarily use that program as a whole.
Yep, same for me.
Okay, so apraxia most often does not occur on its own. So we kind of think of it as doesn't occur in its own bubble. A lot of things or comorbidities occur with apraxia. Some of them are, got hearing loss. You're going to see a bunch of them on this screen. I'm not going to read it all off to you. You've got them there in your handout, but it's rare that it does occur in its own bubble. The presence of one or more additional conditions with apraxia can mean a poorer prognosis, depending on what the other issues are that are occurring, because it can affect, some of the things we'll talk about later, those prerequisites to learning. Some of the comorbidities like behavioral disorders, I'm sure a lot of us have experience with those children that just come in and they are just so frustrated. And those are the main kids that we're trying to address with our presentation, is when you've got these behaviors that are really just detrimental to their success, what do you do? What path do you take? We're going to dive more into this presentation, and we want you to encourage you to do your own research and you use your own clinical expertise on whether these strategies are going to be beneficial to your caseload. We also want to encourage you to always honor the students' or patient's autonomy, consider what's important to them, and think about the neurodiverse populations. So Lori briefly talked about dynamic assessment earlier. We're not going to cover in this presentation what exactly all the details of a dynamic motor speech assessment might look like, although we're happy to answer those questions for you. But a dynamic assessment in general can go far beyond seeing their speech skills and tell you a lot more things on their readiness to learn and what path to take, if you're going to take that motor speech approach or if you're going to take more of a functional language approach. So I like to start my dynamic assessment from the minute I pick them up from the waiting room. We do a family-centered care approach, so the parents come back or the caregivers come back with the child, and I can already see kind of the dynamic between the family. I'm looking at, is the child already talking coming in? Are they using gestures? I'm trying to get a whole picture as we're just walking down that hallway. Once in the therapy room, we like to use a lot of play-based tasks that are really good informal tools. Standardized assessments are just those one little clips, and I know a lot of us only have a short amount of time to assess a child, but we like to use blowing bubbles or wind-up toys or maybe some pretend play schemes and kind of really dive more into those IQ. But it can give you an idea of what the child is doing in terms of functional language. This may be verbal or any nonverbal means the child has for communicating various intents. Keep in mind their behaviors might not be what we are expecting a child to communicate with, because a lot of these children are communicating in their own way, in a way that has worked for them and that has been reinforced at home. So keep looking for all those small nuances, things in the face, the way their hands, the way their shoulders are pointing. I'm looking at the whole big picture. They can help us really assess that learning readiness of what skills does the child have or not have. That tells us whether they're ready to participate in therapy. So we're really, at this moment, we're trying to figure out, are we going to go that functional language approach or that motor speech approach? So some of those prerequisites to learning are going to be on this slide. Some of them are listed here, but we usually like to start our review of a child's readiness by looking at their case history. All of us usually have case history forms that we give out, so I try to find what else do I need to find during this evaluation, such as, we're always looking at, of course, are they talking, what sounds are they making, that vision and hearing piece, but also how engaged are they with you, an unfamiliar person? How engaged are they with their caregiver? Because we have children that will come in and doing something with a therapist is so hard for them. But if we can teach the family to do the therapy and they're more engaged, then there's our window to success. They are ready to learn with that caregiver. But I also look at what are the family's goals? What do they want their child to be able to do in 3 months, 6 months, a year, just to kind of really gauge what are we working toward together as a team.
So with all of that information, that kind of can help you decide which direction you're going to go. With these kids that are really complex, you know, it's kind of too much to try to target everything at once. And especially with the push towards episodic care and you know, just really focusing in on narrow plans of care that really help kids make progress. That's kind of what we've shifted towards. So in our plans of care, we kind of will pick a narrow focus, really work hard on it, and then maybe give a therapeutic break before we come back. And we're going to talk through a case study that highlights exactly that process. So we kind of have this little you know, cheat sheet for you about kind of how you can think and ask yourself some different questions to help you determine maybe what to focus on with a particular child. So the first question you might ask yourself is, are you seeing that the child has functional language already? Can they communicate, you know, basic wants and needs to familiar caregivers? Now we know that they're probably fairly unintelligible and they may be using a lot of nonverbal communication, like Teresa mentioned. They may have some signs or some signs that they've been taught, or they just may have, you know, some idiosyncratic language that they've come up with, gesture systems and things like that. So if they have a lot of functional language already, they're understanding really well, they're really communicative in their own way, you know, that's one thing. And if not, that may be a different route that you go. So if there's not at all, we really feel like trying to hone in on that. Maybe there's some social interactions and joint attention things that you need to address. Maybe we need to get them a gesture system. Maybe we need to go AAC, which we'll talk about a lot more in depth later. But those are some of the decisions that you might consider. If we do have some functional language, but not a lot, maybe that's also an area you want to focus on. You might take more of a combination approach between working on functional language and also really nailing in speech production as well. But like I said, if you've got lots of functional language, then maybe moving on to the second set of questions. So what does the child's engagement look like? How well do they attend to tasks? We know some of the things that I've described with those motor-based learning treatment strategies. They require decent attention and motivation and participation because we are really trying to drill these sound practice and build those motor plans in the brain pathways. So what does that all look like in this child? If we don't have a lot of skills in that area, we may also want to kind of move to a combination approach and fall back on, yes, let's build more language, maybe pull in AAC, some other route. But if you feel like they're really great, then you may say, hey, let's move on to speech production. And I really want to focus on that as my priority. So let's look at just the first little tidbit of our case study. This is a 5-year-old girl, and so she came to me first. She has a history of microcephaly. She had a NICU stay and some birth things, an anoxic event, I believe. She had been in therapy before she came to see me at age 5. This ECI is our early childhood intervention in Texas, and she was in home health, and she was diagnosed with CIS right before she came to me. We started working later on. She's diagnosed with ADHD and intellectual disability through the school district. And I saw her for a couple of years in addition to the therapy she was getting through school. She was really unintelligible initially. So kind of thinking through these steps for her. Did she have functional language? She had a lot. She is the most talkative little girl. And she also has a ton of motivation and a ton of social engagement. However, her attention, remember the ADHD, was really significantly impacting her. So I did end up choosing that kind of a combination approach. Part of the reason she was unintelligible was her apraxia. Part of it was language. She scripted a lot. She kind of was stuck, and really in her intellectual disability, I think that's where some of the scripts came from. In routines, her language was very routine based, and if you didn't have a context for it, you were lost. So that is kind of the beginning for her. Later on down the line, we did move to more language and social, and we'll talk more about that as we go. Okay, so we'll come back to her later. We've talked about a lot of things to consider during assessment, but we want to define a few things for you before we move on and talk about treatment. And so this idea of antecedent behavior consequence, I don't know if you're familiar with that or have heard that before as like a behavioral analysis, a way to look at behavior of the children that you're seeing in a really non-biased way. Because we want to move away from thinking about children as bad, or they have a bad behavior, or they're being defiant, or you know, we hear from parents all the time, well, they're just lazy. So we definitely want to move away from that and move into really figuring out what the causes of the behaviors are that we're seeing. So to define this for you, the antecedent is what happens just before that behavior that you're seeing. It's not necessarily a cause. It's more, you can think of it more as like a trigger. The behavior, of course, is the thing you see. It's what you can name. This is what happened. It's a tantrum. It's the child crawling under the table. It's, you know, what you're seeing. And then the consequence is what happens afterward. So, you know, if you are seeing a toddler screaming and crying in Target, and that mom, that poor mom, I don't know if any of you have parents are parents, but you've been there if you are, is trying to figure out what to do. So the consequence might be that mom calmly picks up the child and walks them out of the store. That is one consequence of behavior. Or a consequence could be mom gives in and he gets the toy he wants and they go check out. Or maybe that mom has lost her cool and she starts yelling. So getting yelled at is another consequence. So we want to think about consequences as they can be good, they can be bad, or they can be neutral. Okay, so that's a really important thing. Consequences are not always the bad thing that happens after the behavior. It's not a punishment. It's just the thing that happens as a result of the behavior. So there are two times as clinicians, as parents, that we train parents in how to help their children, two times to deal with these behaviors. You can be reactive and deal with the behavior after the consequence, or you can be proactive and try to tackle it here before the antecedent. Okay, so we'll talk about how we can do that. Thinking a little bit more in depth about antecedents. Sometimes you have to dig pretty deep to figure out the true cause of what it is you're seeing, and kind of thinking about everything going on with that child in that moment. So looking at sensory processing. Are we you know, processing all the information in our world? Is it overwhelming us? Are we undersensitive? Are we oversensitive to it? Cognitive factors, like I mentioned with our little case study. So what's our attention like, memory, our language skills, our executive functioning, any of these things. Motor skills. Do we have gross motor skills or fine motor skill deficits that are getting in our way and causing a lot of frustration or anything? And then even considering the task level of what you're asking that child to do. If it's too hard, too easy, it's not at that just right level, that can cause a behavior as well. And then emotional regulation, any challenges with that, mental health concerns, there can be so many things going on in any given child. So thinking back to that child at Target, if they maybe they spilled their juice box in the car, and so they walked into Target and they're all sticky and their clothes are just feeling and they can't deal with it. And so when mom says no to that toy, you can't have something, maybe they just can't keep it together. And so the tantrum comes out, or whatever it is. So there definitely could be more going on to that behavior that you want to take a look at.
So let's dive into modifying activities. But before we do that, Allison, are there any questions that popped up?
I'll give it a second to see if any rolls in, but right now our question box is empty. So I
Great.
think we're good to move on.
Okay, so we're going to dive into some strategies, but of course we want to remind everyone just to use in these strategies based off of the child's needs, not just based off of their diagnosis or personal assumptions on what you might see on that case history or what someone else has told you. It's important that we're mindful of ableism and discrimination, and that we modify activities that support all challenges that may be a culprit to behaviors. You'll also notice a lot of these strategies you can probably use with a variety of kids on your caseload. These are not just specific to kids with CIS, but while we're on that talking about other kids, let's talk about referrals. Of course, if you're noticing there are too many challenges in a specific area that you're having to give too many modifications for, we're starting to get out of scope. So if you're feeling like you're not doing speech therapy anymore, which we have had plenty of kids on our caseloads, we recommend referring out to the best source for that, because we don't want to risk any encroachment. But many times as SLPs, we get to the point where it feels like behaviors are impacting our ability to make progress in therapy. And we know our kids with CIS need so many repetitions and practice, so we start to feel really stuck if the child is under the table the whole session, or turtling into the parent's arms, or trying to open and close the door the entire time. So we're going to give you a lot of suggestions for what might be going on, as you use that A plus B plus C format. But we also want to remind you to get to discuss some considerations with other people in your community for when you decide to refer out for more help with behavior. So let's go ahead and dive into some modifications. So modifications for learning disorders. Oh, and this is Lori. Sorry, Lori.
Oh, you're right. So one of the things we wanted to tackle first was learning disorders, because a lot of our kids with CIS do have these learning disorders in addition. And so kind of when they get to that school age and these things start to become apparent, that's where they may struggle. So learning disorders can run the gamut from specific weaknesses in reading, like dyslexia, in writing, dysgraphia, in math, dyscalculia, or even nonverbal learning, is it's a whole separate disorder category. And usually these learning disorders happen in the presence of normal intelligence on, intelligence testing, for whatever that's worth. That's a whole separate discussion. But there are a lot of opportunities for educational accommodations that can really support kids that may just have different learning needs. So if it's additional time on assignments and tests and things like that, positioning the classroom, so being closer to the teacher, being in kind of in a desk of two groups rather than four, so smaller groups. Being able to use technology to help them. So if handwriting is a problem, being able to use keyboarding skills, and just different things like that. So, of course, these kids are generally in speech and occupational therapies to support them as well. So some of the strategies that we use are when you have a task, to kind of simplify verbal directions a bit more into one step, because the challenges with verbal processing are usually apparent for these kids. And so we can support them in ways that help that. So being able to simplify those verbal directions, providing visual supports, and also relying more on visual cues, tactile cues, kinesthetic cueing, rather than only relying on verbal cues. So that puts a lot less demands on their language system. You can show them what to do, model throughout the task. This lends itself really well to DTTC as a strategy, because you're really the temporal cueing that you use, the timing of your cues, really supports them a lot more than, say, some of the other strategies. So that can be a really nice way to facilitate that. The other thing is to modify the task. So just kind of reading that child's cues and starting to figure out, okay, is this task too hard? We talked about that earlier, the task level and judging that. So just planning a way to make that task easier and more accessible for that child. a great way to do this is through visual support. So there's a lot of different ways that you can use visual supports and different visual schedules. But in general, they just create structure to an environment, or they add predictability. And some of our kiddos really thrive on routine-based things. And so that can be much more helpful to make a task more accessible to them, or to support them through a difficult transition or a difficult situation. So the first type what we'll talk about is visual supports can maintain established routines, or they support new routines. So washing hands, hopefully that's a established routine. We all saw that pop up everywhere during COVID, or a new routine, like establishing an earlier bedtime at home or something like that. Moving to a new, like a new therapy routine, you could use a visual schedule to help you with that. Completion of tasks or helping them participate into a task. So this can really help with breaking down a complex task into its components, or even just something like making a to-do list. We use those all the time. Helping someone by giving them a visual choice, or identifying a place they can respond during a routine, for example, like a book reading activity, giving them an opportunity to participate in that task or that activity. And then also moving to supporting unfamiliar situations or a difficult transition. So moving to a new house, moving to a new school, or even just something simple as moving to a new therapy room. That can be really a challenging situation. So you can support them and give them some consistency and the familiarity of an old routine, and they can transfer that to the new location, and that can be comforting. Here's some examples of ones we talked about. So this one over here in the blue square, just a really simple way to help with kind of regulating transitions. You can take the pictures and move them over to the all done category to help, and that's kind of a little task that they can you know, kind of feel like they have some control over during that transition of, okay, this gets to be my job and I'm gonna move the picture over. The clock is a really nice way to support a morning routine. So it also kind of helps children start to see and sense the flow of time. So I'm waking up at, you know, when the hand is up here at the top, I'm moving down and I should be eating by the time it's pointing to the 3, and then I need to be in the car by the time it's at the 6. And then down at the bottom, now this does not have to be super fancy. I like the one at the bottom because this is what my visual schedule looks like when I forget to set one up ahead of time, and I just draw it on the whiteboard as we talk about the plan. And then as we go, we can just erase it, or they get to draw an X through it, or whatever it is. And then here's some on the right that kind of breaks steps down for some routines.
So one of the other questions we got was about visual schedules and how to get them started. So for me, I might introduce it depending on the emotional regulation of the child or kind of where we are in building our rapport. I might do it with something they're already familiar with and introduce it that way as a transition in one session. Maybe they're already familiar with, we'll take blowing bubbles for an example. So I have them in a cabinet in my room. So then I might show a very broken down visual schedule of, we open the door, we get the bubbles out, we pull out the wand. Because of COVID, we still wear masks. So we wave our wands, we don't really blow them anymore. But I might start with that first. And as you kind of saw the examples that Lori gave, there's so many different ways that you can be playing with visual schedules. It can be in a short amount of time. It can be like, if you're in the school setting, you can have a visual schedule maybe on their cubby when they have to come to speech. Or it can be within the therapy room, we're going to be doing this activity, this activity, this activity, or breaking it down into activity steps. Sometimes kids don't do well with the Velcro. It's more of a distraction. It's a fun sound, I get it. So then drawing on your whiteboard, or writing down. A lot of my older kiddos, we use just a written whiteboard to talk about our day and helping them develop the schedule and giving them choice and autonomy. All right, so let's dive into what about activities for our patients or students that have intellectual challenges. This can impact progress with CAS, especially if the concept of an activity is not interesting or engaging to their brain. It's kind of harder to get those higher number of trials. For this population, we want to consider two things. The first one of which is cognitive age. Sometimes that comes from a psychological evaluation. Sometimes we're not lucky to have that full evaluation done when we get them as toddlers or preschoolers, or sometimes if they're just, we get a lot of patients that are coming from other countries. Sometimes they just haven't gotten on that list for that evaluation yet. So I'll do it through conversation or through play and really kind of see what is interesting for them and following their lead. So then I can kind of gauge what's their cognitive age. And then also consider their interests, which we know is motivating for them. I think we all know we always base activities off of the child's interests. That's when we're going to get the most buy-in, but it's what's important for them. So that's going to be important for me. So we're going to adjust the activities based on these areas by finding more realistic versions. So if you think about maybe your 13, 14, 15-year-olds who might have that cognitive age of more of a 5, 6, 7-year-old, we want to try to build activities that both look at their cognitive age and their interests while also still respecting their chronological age. I find that special education teachers are the best resources for this. I've learned a lot from them. So an example might be with a 13-year-old with CAS that I had on my caseload, had the cognitive age of a 5-year-old, loved cars, absolutely loved cars, could talk about them all day long. So we found a bunch of pullback cars that look like actual vehicles instead of the caricature ones that maybe Fisher-Price sells. We found these just on Amazon. I always see them in gift shops when I'm traveling that look like an actual Mustang, a Ford Bronco, a rally car. So those are, we're trying to use those because they look more chronologically age appropriate. So then we could work on phrases like car, go, or nope. We would also watch rally car races on YouTube and then reenact the actions with our cars while targeting like maybe a CV, such as beep, 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 or go, go, go. So really adjusting to that, really thinking about the whole picture, the interest, the cognitive age, and that chronological age is important for this population. Next of which is routines. We all have routines. Even if we're traveling, we've got routines. If we have routines in the morning to get ready for work, that's the same with our patients. Routines are simple, they're structured, they're repetitive, they're predictable, and they're finite. So routines, we want to simplify them. We want to break down the tasks into separate parts. That naturally just simplifies them. If we say get ready for school or get ready for work, if you think about, oh, I got to get ready for work, think how many steps you have to do to get there. That can be overwhelming for our patients. So that's why if one of the questions we got was setting up a session. A routine is a great way to get your kids more buy-in because then they know what's going to happen next. Most of my sessions for my littles come in, I get them from the waiting room, we greet each other, I've got a door that goes down my hallway, we work on, if they're working on open or go or something or help, we use that to get that door open, we go to my room, and then we start the session. And most of my kids, we do some things in the room, and then because most of them have so much energy, we then go to a playground or a gym. And that's my routine every single time with that kid because it's predictable. Using routines, not just in this population, but I mean, it helps with mental health issues such as anxiety or trauma. We get a lot of children who are currently in foster care and they have trauma. And so we're trying to also think of them and being very trauma-informed clinicians. It also helps with children who have cognitive issues, such as the intellectual challenges. It can also help with executive functioning, you know, those attention to a task, those divided attention, emotional regulation. It can help with all of those areas too. But also just the repetitive nature of routines. It's something we do every time, so that's going to help. You can just change little things little by little in the session. So if they come in every single time we go through my door, we go into the therapy room, I can then address maybe a different word that day. Or if we go to the gym, we can do slides instead of swings and working on different things within that routine and doing little by little changes.
I'll also add that I like to use a routine that is something so super simple. But for my kids with CIS, when I'm asking them to do multiple repetitions of a word to get that motor practice in, that can be overwhelming for them too. So a simple routine of just holding up my fingers, whether I think they can get 3 trials or 5 trials, and just counting them down non-verbally just as they go and as we're practicing together, I think really helps with that finite piece of it, that they know, because we've done it so many times, that when they get to the end, like they're done, and I'm not going to ask them to do anymore. And sometimes that helps them be like, okay, I can make it through 3. We all tell ourselves that thing.
Yeah, and just like Lori does, I also tell the kids 3 tries. It doesn't need to, yeah, because if a lot of these kids they're so aware that this is hard for them. So I just tell them 3 tries. I'm not expecting correct on all those tries. That's something I end up coaching a lot of families through, is we're not aiming for accuracy. We're still trying to support the child's ability to do these things and feel confident in doing these things and willing to try. So I just tell them 3 tries, you got this. And so that also just helps them realize it's simple, it's finite, I can do this.
Exactly.
So modifications for attention challenges. So these might be the children on your caseload that have ADHD or ADD, or may just need some support to achieve those higher number of trials. And when we say higher number of trials, we're trying to aim for 200 trials in 30 minutes. That's daunting, especially when you've got this kid the first time they come in and the first thing they do is crawl under the table or crawl under a chair and just shake their head at you or close their eyes. But that's kind of what we're aiming for with all of these modifications. If we're doing a motor speech approach, is we're trying to aim for those 200 trials in 30 minutes. Something to think about with this population is it's not just attention. Think whole picture executive function. And what I like to think of is the regulation, emotional regulation bell curve. So if you take a bell and put it upside down, the top of the bell is the most optimum learning time and readiness. And to the left is understimulated, and to the right is overstimulated. We want to gauge where that child is on that bell and provide support to get them to the top of that bell curve, which might look different for every child. So some of the ideas for attention challenges are shorter activities. The child that we're showing in our case study has attention challenges, and so she has a lot of activities that we do in our session. We might do 6, 7, 8 activities in our hour-long session because that's what keeps her going. That's what keeps her engaged. So shorter activities. Something else I like to do is also mixing it up. And what I mean by mixing it up is if you've got a kid that maybe is under-regulated, they're probably like laying their head down, they're laying their head back, maybe they're looking a little sleepy or not very engaged in your session. I might go up and down between, like, we're doing something at the table and then we're doing something more active in the room. Maybe we're hopping on some dots or playing hopscotch or playing basketball in the room and then coming back to the table. This works vice versa for those children that have short, high energy attention spans, where you burn some of the energy, bring them back to the table. Burn some more energy, bring them back to the table. Another way is visuals. We've kind of addressed that already, but that hits that executive functioning piece of helping them be organized. And like I mentioned earlier, it's especially as they get older, I want to give them the choice of making the decision of exactly what happens in the session. So using those visuals to help them be organized, but also giving them the skill to organize themselves. I'm not doing all the work. So that question of how do you set up the session, I may just pull out some of those visuals, have them ready, or have my little whiteboard ready, and then we get in. That's the first thing we do. That's part of our routine, is we write up our schedule, or I have the visuals just to help support us to get through those high number of trials. If they love Pokemon, we'll have a Pokemon visual or something that way, just to kind of keep them attending to the activity. And lastly, since we have a lot of OTs in the audience today, we like to think of those sensory needs. So we lean on our OTs a lot for our patients to give us ideas what work for them. A lot of the things that I use in my session are heavy work, like pushing a weighted cart, where we thankfully have like a wooden cart that you can adjust the weight on for different needs. We might also look at, do they really enjoy swinging or sliding or like getting their hands into things? We've got also OTs that also recommend the brushing protocol for some of our families. But we really do lean on those OTs and really considering those sensory needs, such as lighting in your room, the type of seating you're in, the level of your voice. I've got some kids that they really like it if I go down to a very soft, very slow, just to keep them regulated and keep them calm.
All right, so we are going to circle back to our case study and check in on, because this little girl had many of the things that we've talked about. I want to show you just a little introduction video to her and then talk about how we use this which one of those strategies we used for her. So we definitely had to match her interests. And early on, she still is really interested in her family members, and that is a big motivator for her. So I would create activities where, and this was during COVID too, so we were on teletherapy, and I asked mom to give us just some pictures of her family, and I kind of cropped out their faces, and we use those in a lot of different activities through the screen, that every time she saw it, she would get super excited to see her sister's face and her mom's face. And funnily enough, all those words were the words we were working on at the same time. Mama, daddy, in phrases to build some of her intelligibility, and her sister's name as well. So that worked out. Simple activities, we really shortened down, kind of did more child-led play. I just integrated our speech targets in that way so that, just as I might for a much younger child. I did really quick, short activities like Teresa mentioned. You can mix it up, go back and forth between things. She really responded well to reinforcement, verbal reinforcement, any praise. She loved it, soaked it up. And we did lots of movement breaks, and I just had her stand a lot of the times instead of sitting. That worked for her, that it just kind of gave her body enough input that then she could really focus in and participate in what we were doing. So real quick video. Let's move on to a little bit more about sensory challenges. We'll move through this quickly because Teresa talked about some of it, and I want to make sure we get to all the rest. But just kind of a real quick overview, we are considering, the original 5 senses that we all learned about in kindergarten, but also there are 2 more. So we also consider the vestibular sense, which is the body's sense of posture and balance and spatial orientation, and then also proprioception. So the body's sense of position relative to itself and how you move, and then like pressure on the body. So those 2 are kind of more internal senses, but those are the ones that a lot of times impact our kids most significantly. So the first step to kind of figuring out a child's sensory preferences is really just to watch them. What do they like? What do they dislike? If they're undersensitive, you can usually, seems like they're seeking more of that sensation, versus if they're oversensitive, you might see that they're breaking down because it's just too much, or they're in distress from a lot of that. So kind of moving into what you can do regardless of if there's hyper or hyposensitivity to anything. We have deep pressure, so that gets at your proprioceptive sense, getting a tight hug from a parent, or sometimes, even just if a child's sitting in front of me, I'm kind of behind them and I'll put my hands on their shoulders and just kind of squeeze their arms in toward their body, or having them, sometimes kids have weighted vests, or they have like a lap buddy that they can sit on. We'll give them a little bit more input to their body. Heavy work is another one that gets at their proprioceptive sense. So that's anytime you're loading major muscle groups. So if they're carrying something heavy or pushing the cart, like Teresa mentioned down the hall. I love working these in between speech production trials. Like Teresa mentioned, we're trying to get them moving, but we're not just moving for the sake of moving, we're moving in a focused way. So we're not trying to get all crazy and out here, we're trying to bring focus and attention in. And so having those specific activities of movement that's specific can be really helpful. Swinging is another one, and then sometimes even just having a fidget toy. So, something simple that's not going to be super distracting for them. like even just playing with a paperclip or something like that, if that's age appropriate. You know, having them sit on a therapy ball or on a pillow or one of those little pad things that are like a squished ball, where they just have the ability to have a little bit of movement, and allowing that movement, because it really just, their brains, they've just got to move to learn sometimes. So those are some good ideas. This one is really just kind of a cheat sheet for you, just some things that kids you know, may have preferences for in different senses. So you can refer to that. The top set of boxes is kind of what you might see preferences for children with hyposensitivities, and the bottom hypersensitivities. The other thing we had for you is a resource on the very last couple of slides, is the alert program. It is a resource that I have used early on. It's a great program that talks about self-regulation, and they kind of use a car metaphor and talk about how your engine's running and how do you need your engine to be running for that activity that you want to do. So if you want to go play a basketball game, your engine better be up pretty high, versus if you're in the classroom or you're in the therapy room and your engine is really high, then you're, you know, it's not going to help you do what you want to do in that situation. So helping kids learn through self-regulation that way.
To talk a little bit about those sensory preferences, a question that we get pretty often is about self-stimulating or stimming behaviors. So as you're considering those strategies that Lori just talked about, I want you to think about, if you've got a child that is doing those self-stimulating behaviors, the goal is not necessarily to stop those stimming behaviors. If the stimming is helping them stay regulated, and it's not impacting their ability to learn, and we can give them support for those, I let my patients stim. If they want to hand flap in my sessions, they are welcome to. If they want to stand, hold onto the table and kind of jump up and down a little bit, and it's helping them stay regulated and engaged, I let them. We're really starting to move all of our, just the way media is going, everything right now, that neurodivergent platform of really considering everyone's needs and not asking everyone to fit in a box. I really do think about that in my sessions when I'm trying to give support and modifications. So our next area is modifications for physical challenges. I know we've got PTs and OTs in the audience, so this will kind of be a review. I'll do this pretty quickly, but we've gotten all of these from the PTs and OTs that we work with. So of course, if you've got those handy for you that you can talk to on site, or that you've got a local one that you can lean on for these needs, by all means, reach out to them. Some of the activities that we might use is adjusting for different puzzle sizes. So then that fine motor skill, those visual motor skills, makes it easier for them. So then we can get to those trials and talk about and the puzzle actually gets in a appropriate amount of time and they don't get frustrated. Another one that we use is kind of getting them moving on maybe like a little scooter board, and sometimes I'll pull them on a little rope and we can work on go or no, stop, fast, words like that, and they love it. Kids love bouncing against the walls in our little hallways, or being able to control the speed that I'm pulling them on. They find it very engaging. Another one is if your kiddo loves drawing or anything, our OTs have recommended some modifications for that to help with grasping. And then, of course, some tactile and dexterity things to kind of help with visual. This is obviously an AAC device. This is a mid-tech, but those little tactile things can also help as well. So if we were to kind of go big picture, modifications for behavioral challenges. So the first thing we always want to think about is if there's a better source or something that we can add on to what they're currently receiving. Counseling, other therapies. One of the hot topics right now is ABA. So if you are considering ABA for a child, I understand it's a very hot topic right now, but we also know that many communities that aren't in support of that. So we really encourage you that if you are thinking about that, it may be appropriate for your patient to really talk to the team. That team includes their family, getting their idea on what they think about it, really helping them understand what ABA is and giving them the tools for them to make the ultimate decision. We just want to say that if you're making these type of referrals, to get to know your local area providers. We have found some great providers in our area that we lean on for, supports such as behavioral modifications or referring to them, because they know they can lean on us for things as well. So if you're looking to make those referrals, make those recommendations, before you do that, get to know people in your area, so then you actually know where you're sending these children to. Our goal as SLP should always be to support those individual needs and that neurodiversity. So we want to make sure our referral sources are aligned with those as well as the child's and the family's goals. So some strategies you can use, we're going to dive a little more into these in the next couple slides, but choices, some visuals, token boards, both of these, and then of course some behavior and verbal praise. But some of the behavioral challenges you might be encountering might be like bipolar, OCD, ADHD and ADD, which we've kind of already gone over, anxiety, which we're seeing a lot more with children. It might look like they're irritable, clingy, avoiding situations. Sometimes these children may have anxiety about things that parents wouldn't expect, which results in a lot of parents interpreting that as stubborn, lazy, or a bad child. So we want to step back and look at that antecedent. Is there a more internal root cause for why that child is acting that way? So we really want to think of big pictures. No child is bad. They're just misunderstood. So some of the things you might see or have heard of, some of the things that we use are reinforcements. Those might be things like token boards. Using external reinforcements is also a little bit of a controversial topic right now. We like to see it as we're using reinforcement to build up that internal interest in doing the trials that we're wanting. So what you see is usually those token boards, like the ones at the top two, with the magnet tiles and the timer also in the same picture. If you're doing a token board, start with less. Sometimes we have all those spaces on that token board and we want to aim for that first. Okay, we're going to go for 10 trials, and we're thinking so much that our children can do that, but we want them to feel success first. So we might start with just 3. Wonderful, you did it. Let's go play. And sometimes while we're playing, I'm just giving them some of that modeling of the language I'm looking for, or modeling the words over and over, but I don't have that expectation during that reward or reinforcement time. You see some other examples here. We've got kind of like a game board piece. We've got some that kind of talk about where the boundaries are in the session. Those are the good choices, poor choices. And then something as simple as you see at the bottom of the screen, here's the 2 things we're doing, and then we get to do the thing that you have selected for the day. So those are some of the examples for reinforcement. And then behavior-specific praise. We use this so much. This is really to build that intrinsic motivation to doing the activities. These are a great place to start. These are adult-initiated statements that communicate the specific behaviors that you want the child to do more of. So instead of saying good job, we're going to be specific. Good job keeping your bottom in the chair while we work. Or instead of you got this, I would be more specific. You're really getting good at using your lips for those sounds. I will give specific feedback about what their mouth is doing. Wow, your tongue went to the top of your mouth. That was great. Wow, did you hear that? Your voice changed. It went up and then it went back down. Or wow, you made that long and then short. I'm very specific. I hand it to these kids too. I really think that they can pick up on a lot of these words, and just the positivity in my voice, we find really helps that intrinsic motivation.
And I will say that's a core feature of motor-based learning as well, is the type of feedback that you're giving. So this really aligns with that as well. All right, we wanted to talk about autism, excuse me, as its own separate category, because it is probably one of the most common comorbidities that you see for children with apraxia. study in the Journal of Developmental and Behavioral Pediatrics showed, I think this was a couple years ago, that almost 2/3 of children who are diagnosed with autism also have apraxia. So I don't know that that study's been replicated, but that is out there, that it's pretty significant. And like Teresa said, we know a lot more now than we used to. Many autistic adults are sharing about their experiences in different types of therapies. So we just encourage you to seek out their perspectives and learn more. We can't dive too deep on that today, unfortunately, but what we wanted to focus on is a couple of scenarios that you might come across working with children with CIS as you're trying to build their motor planning and really work on speech production, and kind of some ideas for how we've handled it. And the first is that first thing to consider, many autistic children are not analytic language learners. So they don't learn single words and then two-word combinations and then simple sentences. Rather, they are Gestalt language learners, so they will learn in larger chunks at first, which are called gestalts or scripts. So you're hearing this through, echolalia, either immediate echolalia, or you're hearing them, repeat scripts from TV shows that they love or different things like that. Later on, they start to break those scripts down into their component parts, and they learn, they can manipulate morphemes and eventually create novel utterances. But that is not how their language comes at first. So for, children with CAS, if they're an analytic learner and learning, in the way that we always learned in grad school, you're going to choose a few single words for them and work on those words until they can say them. But for a Gestalt language learner, that may not be as effective of a strategy. So just thinking differently how you might approach that. Unfortunately, there's a pretty big pretty big research gap in this area. Gestalt language learning is really just kind of coming back into awareness in our field. I haven't seen any research about the overlap with apraxia, so that could be an area to look out for in the upcoming research. But so I kind of think of it as circling back to that decision map that we looked at earlier, considering those questions about readiness to see what kind of approach that you want to take for that child, and then really considering that in your target selection of your words, thinking about what scripts you're hearing from them, if any, and kind of, again, what areas they're interested in, and kind of really considering that in your target selection for what you're addressing for words. The second area to think about, so we've talked a lot about these motor-based learning strategies for speech, and how much visual cueing is a huge part of that. We love when children are able to look directly at our face and watch our mouth while we're saying the sound, we're saying it together. It's a very effective cueing strategy for apraxia. However, we know that many autistic children and autistic people just don't prefer that direct eye contact. That is not something that they're into. And so asking them to utilize that cue wouldn't be appropriate. So a couple of different options that you have, whether they work or not. You could use a mirror. So both looking into a mirror. Sometimes that is not, that's more of interest to them. They can still see your mouth. Maybe they can't see your whole face in the mirror, and they can really just get a good look at your mouth. You could also wear sunglasses, so you're not doing, that direct eye contact is kind of taken out of the picture. You could also use some video playback. So just take a video of your mouth saying the words at the right pace that they're working on, and then they can practice along with the video, and you can be right behind them, kind of coaching them through it with your cueing. So it really just depends. Some children even they can, they like the face-to-face contact, but maybe for shorter periods of time. So using shorter trials, more frequent breaks. Really, it is just all about reading that particular person and what supports really help them and facilitate their what they're working on.
So I'm going to go through this rather briefly because I know we had many questions about AAC. I want to make sure we can get to that section, but I thought just kind of knowing what CERTS is, which is kind of like a theory and a good way to kind of gauge your session. So we had some questions about some ideas for the school setting. I do find that CERTS is helpful for the school setting because it looks at, Laura, I think there's one more.
Yep.
Yes. So that transactional support section is really helpful in the school setting because it thinks about the people that are involved in the child's life. It thinks about the environment. So CERTS stands for Social Communication, Emotional Regulation, Transactional Support. It was developed by Barry Prezant, Amy Weatherby, and Emily Rubin. It was originally developed for children with autism, but I do use a lot of this to help organize myself so that I can help this population with CIS. So I'm going to go briefly through what each section is. So the social communication piece looks at that joint attention in symbol use. Symbol use is more so that language area. The joint attention one is looking, are they responding to bids for an interaction? Are they initiating bids for an interaction? So the CERTS model can help no matter what direction you're taking your therapy. So if you're doing that functional language approach where you're just focusing on language and social skills, it can help there. It can also help just organize yourself and help support the caregivers or the other professionals in that child's life when you're doing a motor speech approach too. So the next section is going to be emotional regulation. This looks at mutual regulation. So things that we do, like in the picture, things that we do to help a child regulate themselves. We use a calm voice. Maybe we pick them up from the stressful situation and take them somewhere else, or just simply giving them a hug. Self-regulation is what we do with ourselves. So maybe taking a deep breath, removing ourselves from stressful situations. So those are two separate areas with CERTS. So they're looking at, like that bell curve that I talked about earlier, where that top is that optimal learning point, and then you've got the less stimulated, overstimulated areas. They're considering that, which is really beneficial with our children with CIS. These are strategies that also parents can really be involved in, or the teachers or the aide. And then the last area is the one that I think is the most helpful, which is transactional support. So since we're a family-centered care facility, we've got those parents in the room, like I mentioned earlier. But if you're even working with the school staff, parents, teachers, aides, techs, even yourself, these interpersonal supports, which are we following the child's lead or following what their attention is? Sometimes I've got a parent in the room, they're trying to get this child interested in this activity, but the kid's over here messing with the basket that's in my room. And so we're going to follow that attention, look at what the child's looking at, and build upon that. Do they imitate the child? Do they offer breaks? Some parents just want to go, 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 go. They want to work so hard, but the child is now overstimulated. They are now shutting down. So we're going to do that. Preventative care there and work in some breaks, identify those signs. And then learning support. We want to make sure we structure the activity for active participation. We're defining those clear beginning and end. So those learning supports are more environmental things that we're doing. Interpersonal support is what the caregivers are doing, school staff, that kind of thing. So I really encourage you, they have books for the assessment piece, and there's many trainings as well that Barry and his team offer to kind of help understand. There's so many points and so many areas within this model that I think all of it is so helpful.
All right, so let's jump over to our AAC section and kind of thinking about now, why would we use AAC with a child with apraxia? Kind of thinking back to all those prerequisites we talked about. If we're deciding we maybe want to go to work on functional language, or maybe we're working on some social engagement or readiness for learning, and we want to focus on that first, AAC could be a really great tool. AAC can also support a child with complex behavioral challenges. Maybe you've looked at that ABC breakdown of your behaviors and you figured out that communication breakdowns are the cause of meltdowns or frustration and that sort of thing. So AAC could be really supportive for that child in that situation. AAC can be, every child in every situation is different. We used to talk about AAC candidacy, and does this person check all the boxes? Do they have all the right criteria? That, as a field now, we're just understanding AAC is for everyone. So we look at those prerequisites now as more of a way to help us make choices about what system would be a good fit for a child or where we want to start. But knowing that that can change as that person's communication needs change, we're always going to be flexible with our system. So looking at thinking when is the right time to choose whether we go AAC. If the child shows interest, so I just grab, a device, or I grab a mid-tech thing, or I grab pictures wherever I feel like the child might kind of be a good starting point, and I bring it in the session and see how it goes. If the family shows interest, sometimes families come to us saying, I want to start with a device. Sometimes it's a little bit more, we got to get some more buy-in and try it out in the therapy and show families what potential it has. Thinking about how children could access the device, we'll talk about that a little bit more on another slide, but that is a really important feature to consider when you're thinking about AAC and which system to choose. If you are expecting slow progress with communication goals, that could be a really good time to trial AAC as like a backup communication system. I will often explain it to parents as like, this is we have a big gap between what we know or feel that this child can communicate and understands and wants to communicate, and what they are able to do. And so we can use that AAC as a bridge while we're still working on verbal or whatever other families and child's goals are, and just helping us bridge that gap. It can also be a good next step if you've tried a traditional approach and you've gotten stuck, you've had a plateau, you feel like wheels are just spinning and everybody's kind of getting frustrated. I had a child who was very communicative with gestures and grunts, but he was really growing to the point where he needed vocabulary, and we were not progressing with verbal speech at all. And so he tried AAC and he latched onto it like a lifeline, and it was the best thing. Safety concerns are also a big thing. If that child doesn't have a way to communicate basic wants and needs, we really have to get them going before we can really move on to how well they say their sounds. So the biggest strategy for working with AAC and teaching communication through AAC is aided language stimulation. It's the most evidence-based strategy to help kids use a device. It's a really simple tool. So the basic principle is that when you talk out loud, you also use the device, or you show the picture, or whatever level of AAC you're using, you do that at the same time. So we are modeling use of the AAC just like we model verbalization. So kids pick it up incidentally as well as through direct teaching. AAC is also a really great teaching tool for the things that we're addressing with Apraxia. Some systems are built, their vocabulary systems are built in a way that promote motor planning. So that could be a really good system for our kids with Apraxia. We also generally teach vocabulary using a core word approach, which is really similar to how we do with Apraxia. So your core words that you're using that you're working on their intelligibility for also maybe the core words that they can use on their device. And then, of course, AAC encourages participation. So kids are going to have access to communicating in a way that maybe they hadn't before, and that's huge. So having conversations, participating in the classroom, participating in a family activity, being able to ask for something that they want for dinner can be really big, and helping them connecting to other people in their world in a way that maybe they haven't been able to do before. So what about if parents and the child wants to work on both? One way that I will do this is kind of use that device for vocabulary development, use it for fringe words, words that we're not going to be able to say for quite some time. And then our core words, that's what we can use for verbal speech practice. So that's just one way that I've done it before.
So for our PTs and OTs in the audience, here are some things that if you've got a patient of your own that comes with a communication device to your sessions, because we encourage them to take it anywhere and everywhere because it is their voice. So here are some things that you can do to support your local SLP or support these children's ability to communicate. So as Lori said, that modeling on the device, so aided language stimulation. If you are scared to touch the device, ask the parents if they can do it too, or ask permission to touch it. Sometimes, especially our older kids, they've taken ownership of their device. So you want to ask them, is it okay if I talk too? Can I use your device to talk? I'll do that almost all the time with my patients. I start them little because it's their device, it's their voice. I'm going to ask permission. I'll then invite them to use the device. They get into other therapy sessions, and there's other words that can happen in those sessions that don't naturally happen maybe in a speech session or at home. So invite them to use their device as well. Do you want to tell me something? I'd love to hear you talk, and just really encourage them to use that device as well. But we also want to lean on our PTs and OTs to advocate for that device use and for AAC in general. If you've got a kid that comes in, they've got interest in communicating, it just is not getting out here, advocate for them to maybe seek out an AAC evaluation or talk to their speech therapist about other routes, or just advocating for device use in general. We want to get that device being used in the community as often as possible. So incorporate that device into your sessions. Please don't be scared. Please really use it to model on it or see the words that are on their device. Oftentimes we'll hide some words just to kind of get that kid going on those power words. Look at the words that are on the device and incorporate them into your sessions as well. So quick system overview of some devices of where do you start? Find your consultants. If you're considering a speech generating device, so a little bit of background on AAC, there's kind of 3 levels. You've got your high tech, which is what you see on the screen here. Those are your tablet-based devices. And then you've got mid tech, which are recorded devices. And then you have low or light tech, depending on your terminology preference. And those are more of your picture Velcro systems. So if you're going for that speech generating, that high tech, look at your consultants. You can go to that Tobii Dynavox website or the PRC Saltillo website. They've got a direct link. You can find that consultant. Email them. They are all wonderful. All the ones for our areas, we're so grateful for them because we reach out to them and lean on them quite often. Some of the brands that we do use are PRC Saltillo, Tobii Dynavox, Talk to Me, AbleNet. All of those are great options. They all have different language systems. So it's a lot of, I trial a minimum of 3 with my patients before I move toward purchasing one for them because I want to make sure it's the perfect fit. I'm not going to assume a need, but I will kind of lean towards one way. If they've got, someone mentioned that whole body apraxia, they've got that, maybe that lamp with that motor planning approach might be most helpful for them. As well as we do consider access. So access might be a direct touch with just their finger. They might also need assistance from a key guard that surrounds each button or a touch guide that has just a little circle so they can really just get the pad of their finger in there. Other ways of access are head pointing, eye gaze. They've got a little bar at the bottom of the speech generating device, stylus, scanning. So there's many different ways of access. You really need to consider the patient as a whole. And then some backup options. This is a common question. We get this all the time. What if you don't have a device in-house yet, you're waiting to get one in the mail, or you've just sent back a rental? What do you do when you don't have a device to trial? So you might consider laminating some pages. These can go home with families. Laminating, and you can, if you're working on masking some of the words, just taking some painter's tape or masking tape and covering some of those words up so it's not as overwhelming at first. Most of the time we get the overwhelmed question from our parents, so this helps them as well so they can start using it at home and not be overwhelmed themselves. Other options are also to download. PRC has a system called New Voice where you can download to, it's the PASS software, you can download it to any Windows computer and you can model on the computer. This is free, parents could do this at home as well. Or you could have it if you have a laptop, a Windows-based laptop in the school setting. Mine is touchscreen, so I'm grateful that I'm able to model on my computer if I don't have a system available, and it works just like a tablet. But you can also work on foundational strategies during that time, modeling that core vocabulary, acoustic bombardment, a lot of those acoustic highlighting, all of those foundational strategies that we would teach in a traditional language approach. You can now be teaching that to the family or implementing that in your sessions when you don't have a device handy in that moment. So we are nearing the end of our presentation. We would love to hear something you learned or were reminded of during this presentation, or if you've got any questions for us that we could possibly answer. I'm kind of going through what I jotted down earlier, but if you want to type in your chat, your question box, something you learned, reminded of during this presentation, or any pending questions you might have, and I'm going to go through the rest of my little notes I took and we can answer those as well.
Fast progress with AAC going from 12 button array to 72 button array in 6 months be a sign that apraxia is present. Also, when they think they are saying different sound words but still saying the same sound, i.e. da for both dada and mama.
So I'll take the first half of that question about AAC. For me, when I see a kid move that quickly with AAC, it really shows me that they've got an intact language system. They've got vocabulary, they're building sentence structures. So it does give me an indication that something else is going on. There's a wall, a block that the reason why they're not getting their words out. But whether or not it's apraxia, I need to lean on that Mayo 10 that's in your handout to really do that differential diagnosis on if that's the exact reason of why that's happening. Because apraxia, it's rare and it's overdiagnosed. So if you are thinking about that, really doing that dynamic assessment and looking at that Mayo 10 will be helpful to really figure out if it's truly apraxia.
I think the second part you were asking is that when they repeat something and they think they're saying it right, is that a characteristic of apraxia? And I would say, while we see that in children who are apraxic, absolutely, that we also see it in children with many types of speech sound disorders. So that's not a diagnostically significant feature, if that makes sense.
All right, the next question, how can we differentiate planning with processing?
Planning with processing. Okay, so processing is more taking information that you're receiving from the outside world, whether it's sensory, whether it's auditory information, language, whatever it is, visual information. And then processing is what your brain does with that information in order to respond. Planning, on the other hand, is output. So it's the very first step in output that you, so if I want to say a phrase, the very first thing that my brain has to do is plan the motor sequences that will make that happen. So that's kind of the difference, input versus part of output.
All right, going back to the AAC devices, what if they don't want you to touch their device? Is a mirrored device okay for modeling?
Yes, so we get that question a lot, and I get a lot of kids that way, that it is theirs. Great, we have addressed ownership. So I will try to bring a second device, a laminated board if I don't have a second device, having it up on my computer, and sometimes just modeling the words and inching closer and just pointing. You can do that really far point for them too, and inching closer. They might want to inch their way into feeling comfortable you touching it.
All right, so many comments coming through for your poll question here. So excellent examples of modeling to encourage use of AAC. Thank you. So great to know that all the OT strategies that I already use in my work with children will also support children with CAS. I like the idea of wearing sunglasses with people who don't like eye contact. What I learned, high rate of comorbidity of autism and CAS. Awesome. All right. And I think that clears our question box. So thank you for presenting and thank you everybody for